a lifeline for millions of Americans and are a market miracle that allows for accessible treatments. That is why it's so important that we have transparency into their supply chains and full confidence in their production. As we know from the FDA's own people, they have allowed importation of drugs from facilities that are non-compliant simply because of the potential for shortage, which we should be making these drugs here in this country in the first place. In our previous two hearings on this topic, witnesses have highlighted the ways that we can bring back domestic production in an affordable, market-driven way. Today, nearly 80% of the active ingredients in our prescription drugs come from foreign sources. That's foolish. That means we depend on our adversaries for the very medicines our families and seniors need to survive. It's not England, it's not Germany, it's not Japan, it's our adversaries. Consumers, pharmacies, and big buyers like hospitals don't even know the full extent of where those drugs are made or what's happening inside the plants that make them because we don't have country of origin labeling requirements. We've seen the results of that dependence: contaminated drugs, dangerous recalls, and shortages that force doctors and patients to ration care. It is unacceptable that the most advanced country in the world can't ensure a steady, safe supply of basic medicines for its own citizens. The solution for this is very simple. We must make drugs in America again. The health and safety of Americans is too important to leave in the hands of other nations, especially our adversaries like communist China. When we manufacture here at home, we can control quality, strengthen oversight, and protect patients. We also get the benefit of creating good-paying jobs and growing our economy. Today's witnesses are proof that American manufacturing works. These companies show that it's possible and profitable to make safe, affordable medicines in the U.S. However, they also face challenges that Washington has helped create. Red tape at the FDA delays approvals and drives up cost, something I and many of our colleagues are interested in fixing. And by the way, I want to thank the ranking member, Gillibrand, because she has been a complete partner in the report we put out and these hearings to make sure we get change. Current procurement rules for government agencies, large purchasers of generic drugs, reward the cheapest overseas bidder rather than the safest or the most reliable product to the detriment of American manufacturing. The difference in cost is often negligible, and foreign governments manipulate their pricing to undercut American manufacturers. The result, a broken system that leaves our patients vulnerable and our businesses at a disadvantage. The federal government should lead by example. The VA, Medicare, and our military health programs should prioritize American-made medicines. Unfortunately, they don't. Taxpayer dollars should support our American workers, not fund companies in China with ties to forced labor and that don't meet our safety standards. This isn't just an economic issue, it's a matter of national security. Americans should never have to wonder whether their blood pressure medication, their insulin, or antibiotic was made safely. We can do better, we must do better. Together, we can build a stronger, safer, more self-reliant medicine system here in America. And now I'd like to recognize Ranking Member Gillibrand for her opening statement. And again, I want to thank her for being a complete partner in getting this report out and these hearings.
Thank you, Mr. Chairman. Thanks for calling the hearing, and thank you to our witnesses for testifying today. We're very grateful for your contribution. I look forward to continuing our conversation about how we can improve the quality and reliability of our generic drug supply. This is an essential issue for our committee to examine, as many aging Americans, including over 53 million Medicare Part D enrollees, rely on at least one generic drug to treat a wide range of medical conditions. Unfortunately, the supply chain for these crucial drugs remains vulnerable to disruption, and we consistently witness issues with the quality of foreign drug products, causing key medicines to go into shortage. It's unacceptable. Every American should have access to safe and affordable generic drugs. Particularly as older adults navigate the complex, difficult health conditions that they face, they shouldn't have to cope with worsening symptoms, skipping doses, or trying to stretch medicines further because they can't afford them. This is an existential issue for a lot of older Americans and for New Yorkers. I've heard from many New Yorkers about this issue. One of my constituents from Brooklyn told me, for the past month and a half, I've been unable to receive my generic medication because of shortages. Much of my day is spent going back and forth between pharmacies and my doctor's office, playing phone tag when I should be doing my actual job. I've even had to spend money on third-party services to help me find my medication when I'm unable to. The entire process is exhausting, demoralizing, and dehumanizing. A key factor driving up these supply chain disruptions is that due to the extreme cost pressures and concentrated sourcing, key starting materials, active pharmaceutical ingredients, and finished dosage form generic drug products are increasingly made outside the United States. We've seen the number of U.S. facilities that formulate generic drugs fall by 27% since 2013, and in the same time frame, we've seen 38% decrease in the number of domestic facilities producing active pharmaceutical ingredients. In fact, 83% of the top 100 generic drugs taken by American consumers now have no U.S.-based source of API, and another 11% only have one domestic source of API. This means we increasingly depend on countries like India and China, where the industry has grown for these upstream materials that represent the most vulnerable checkpoint in the supply chain. This is particularly a problem because recent instability in geopolitics and global trade practices is compounding our already limited operational oversight and control over foreign sourcing and manufacturing of these key materials. The U.S. decline in manufacturing has not only led to a domestic job loss, but it represents the vulnerability in the supply chain and increasingly poses a risk to our nation's public health preparedness and national security. To ensure Americans have a reliable supply of safe and affordable drugs, Congress will need to work to make targeted investments in biotechnology research and infrastructure to manufacture these key ingredients in the United States. In addition, we have to examine the underlying economic dynamics in the current marketplace and adjust incentives to fix the race to the bottom problem in generic drug pricing, which can drive manufacturing outside the U.S. and cause companies to stop production of certain drugs and chemicals altogether. I look forward to hearing from our witnesses today to discuss these challenges and barriers the barriers that face this industry. And I'm eager to work with Chairman Scott and the committees of jurisdiction as we address these issues, strengthen our generic drug supply, and bolster our public health preparedness and national security.
Thank you, Ranking Member. I'd like to welcome our witnesses, all of whom are leaders in the efforts to bring drug manufacturing back to the United States, ensure that every medicine we take is safe, affordable, and made to the highest standards. So now let me turn it over to the Ranking Member to introduce our first witness.
Thank you, Chairman Scott. I want to move to introduce Alan Cockle. Mr. Cockle is the Chief Government Affairs and Public Policy Officer at Civica RX, a not-for-profit organization. Civica RX was created by the U.S. health systems in 2018 to address drug shortages by manufacturing quality essential medicines at sustainable prices. Mr. Cockle served on the board of the Reagan-Udall Foundation for the FDA and was a founding board member and vice chair of the Medical Device Innovation Consortium. Mr. Cockle, you may begin your testimony.
Thank you, Chairman Scott, Ranking Member Gillibrand, and members of the committee. I appreciate the opportunity to speak with you today. My name is Alan Cockle. I'm a pharmacist, and I lead public policy for Civica RX. Civica is a nonprofit generic drug company created to prevent drug shortages and to ensure that American patients have a reliable supply of essential medicines. We currently supply 60 health systems around the country with more than 50 injectable drugs. Over 7 years, we've shipped more than 240 million vials. And to do this, we work with a range of manufacturing partners, giving preference to U.S. sourcing. Civica has a rigorous quality oversight process for its suppliers involving in-person facility audits and ongoing quality reviews. This is a unique feature of our supply model. Also unique is that we maintain a 6-month buffer inventory of every drug, and we offer the same price to every purchaser. Civica's own newly built manufacturing facility is in Petersburg, Virginia. Funded partly with U.S. government support, this is a state-of-the-art facility for manufacturing sterile injectable drugs with the ability to make about 90 million vials a year. We have dozens of generic drugs in development for this facility. Civica has a no China policy in our supply chain. both for finished drugs and for active ingredient, unless there's no other supply available. Civica drugs are chosen by pharmacists and physicians from participating hospitals, and they're chosen because they're at high risk of shortage. These are products that are the bedrock of inpatient care and surgery and emergency medicine: antibiotics, anesthetics, blood thinners, sedatives, pain medications. And while these are essential medications, they also tend to be very low cost. It's precisely because generic drugs are so inexpensive that manufacturing has been steadily moving to India and China. Make no mistake, low prices are the principal barrier to onshoring generic drug manufacturing. It costs millions of dollars to bring a generic injectable drug to market, and it takes several years. It requires a costly manufacturing facility and teams of people, R&D, manufacturing, laboratory, quality, and so on. With many injectable drugs selling for less than $1 a vial, U.S. production awfully isn't simply financially viable. If we want sustainable domestic production, we have to be comfortable that it's worth paying slightly more to have a safe and secure domestic industry. We should provide extra payments to hospitals that take quality into account, along with domestic sourcing and buffer inventory. A bipartisan Senate Finance Committee discussion draft takes this approach. And since generic drugs account for 1 or 2% of hospital spending, such a program would have a negligible impact on overall health costs. In combination with these long-term market fixes, Congress should invest now in an insurance policy so that we can deliver these drugs as soon as they're needed. Because it takes years to bring a product to market, we shouldn't wait until after a foreign supplier fails or cuts us off to start developing the drugs we need. But we also can't expect companies to invest in products if they won't recover their costs. Report language in the Senate FY26 Labor H bill instructs ASPR to partner with the private sector for this purpose, and Congress should fund this activity. For a modest one-time expense, we can ensure that domestic manufacturers are ready to go as soon as they're needed. You may note here that I've been talking more about finished drug products, vials or tablets, than about active pharmaceutical ingredient. Sometimes we focus on API because that's where our dependence on China is greatest, but it won't do us any good to bring API back to the US if we don't have a viable market for domestic finished drugs. We have to get that part right. I want to point out that developing a drug for an existing manufacturing facility is faster and cheaper than building an entirely new facility. But when new facilities are needed, and they will be for certain antibiotics and cancer drugs, it will require investments of hundreds of millions of dollars and probably government support with capital, as well as some assurance of sustained demand. With modest changes to the current system, generic drugs can be produced cheaply and at scale in the United States, but we have to commit to making a market that works. I thank you for your attention and welcome your questions.
Thank you for your testimony. Now I'd like to turn it over to Senator Tuberville to introduce the next witness.
Thank you, Mr. Chairman. I'm proud to introduce my witness here, one of my constituents, Mr. Tom Neely, the chairman of Oxford Pharmaceuticals based in Birmingham, Alabama. Mr. Neely is also partner at Prost Companies, a family investment firm located in Huntsville, Alabama, where he is directly responsible for the strategic direction and daily management of Oxford. He is also involved in the firm's real estate investment, including Broadwest, and the firm's manufacturing business, including Dorsey Trailer Manufacturing Company, located in Elba, Alabama, Myco Boat Trailer Company, located in Bradenton, Florida, and Brown Precision Company in Huntsville. Tom holds an extensive experience in executive management, strategic planning, mergers and acquisitions activity, and financial oversight. And by the way, did I mention he's a graduate of Auburn University, War Eagle? Go ahead.
Thank you, Chairman Scott, Ranking Member Gillibrand, and distinguished members of the committee. I appreciate very much this hearing. My name is Tom Neely, and I am chairman of Oxford Pharmaceuticals, a Birmingham, Alabama-based manufacturer of low-cost, high-quality, solid-dose generic medicines taken daily by millions of our seniors. This is a personal matter for me. My wife has mid-stage Parkinson's disease. Oxford manufactures one of her generic medicines, but we cannot purchase it in Birmingham. Hers is manufactured by a Chinese company. Oxford broke ground on a world-class facility in 2015 and began selling generics into the U.S. market in 2019. This period was marked by U.S. generic drug makers going out of business, but we invested $130 million. At Oxford, we feel that high-quality generic drugs can and should be manufactured domestically. We currently make 13 generic management drugs for conditions including blood pressure, mental health, and mild pain relief. When I say we manufacture these medicines, that's indeed true. We transform raw ingredients into finished oral tablets. We weigh, blend, compress, coat, package the tablet while adhering to an end-to-end, very comprehensive CGMP compliant quality process. Unfortunately, in today's domestic market, offshore manufacturing of these generic medications has dangerously weakened our supply chain, with China and India controlling the market. These foreign competitors are heavily subsidized by their governments, and studies repeatedly have shown quality of their finished products is inferior to domestic produced generics. In addition, the three big distributors, PBMs, and insurance companies care nothing about quality, but focus on price. 10 of our drugs have no other U.S.-owned and operated manufacturer, and 3 are classified as essential medicines. These proven generic drugs have been on the market for decades. On a weighted average of Oxford products, we sell 100 tablets for $1.50. Medicare reimbursement for the same quantity and product set averages $13.25, most of which the middleman captures. India and China are aggressive with subsidies, tax rebates, lower land and labor costs, expedited approvals, and billions in grants give India and China companies a distinct price advantage. U.S. plants operate under continued FDA inspection, and we welcome inspections because American patients live and die on the quality of our products. We believe that it is our moral obligation to produce the highest quality generic medicines possible. Many foreign plants go years without inspection. When FDA inspectors do visit foreign facilities, they found appalling practices which would have shut down a U.S. manufacturer. At one India generic maker, staff destroyed documents with acid and shredders to hide falsified safety data. It's within these constraints that Oxford is only operating at 55% of our capacity. We could easily quadruple our monthly output and double our workforce if we also have land and technical capability to build an on-site integrated API facility. But we need policy certainty and, most importantly, committed demand. Federal policy can help create the environment that we need to undertake this expansion. I urge the committee to support 4 concrete and practical actions. First, affirm generic pharmaceuticals as a national security industry under Section 232 investigation. Second, give the procurement priority to legitimate domestic manufacturers through the VA, DOD, and Medicare programs. Reward end-to-end domestic manufacturing through long-term government contracts. Third, support investment in domestic pharmaceutical manufacturing and API production through targeted grants and tax incentives. And fourth, require complete country of origin information on labeling. Patients deserve to know where their medicines are manufactured. Managing mid-stage Parkinson's is hard enough without worrying about the safety of my wife's medications. The 4 solutions mentioned will be vital in changing the landscape of generic pharmaceutical manufacturing in this country. Thank you.
Thank you, Mr. Neely. Now I'd like to introduce Patrick Cashman. Mr. Cashman is the president of USA Antibiotics, the last domestic manufacturer of amoxicillin. Mr. Cashman has decades of experience in the pharmaceutical industry, leveraging international partnerships and holding senior leadership positions at globally recognized pharmaceutical brands. Based in Tennessee, he oversees the R&D, quality, manufacturing, regulatory affairs, and other teams that work to provide the American people with life-saving antibiotics. Please begin your testimony.
Chairman Scott, Ranking Member Gillibrand, distinguished members of the committee. Thank you for the opportunity to testify. My name is Patrick Cashman, and I serve as president of US Antibiotics, headquartered in Bristol, Tennessee. We are the last remaining domestic manufacturer of amoxicillin, the most prescribed antibiotic in the United States. My colleagues and I are in the business of the 3 F's: formulating, finishing, and filling the highest quality amoxicillin in the United States. We never import finished form drugs, and we have never and will never purchase our active pharmaceutical ingredients from China or India. Our facility has supplied this critical medicine to American patients for more than 40 years. Until 2008, every dose of amoxicillin came in this country was produced at our Bristol plant. Then came the years of escalating subsidized competition from Indian and Chinese drug makers. By 2020, our production lines had gone dark, our assets were in bankruptcy, and the United States had become entirely dependent on foreign sources for the most prescribed antibiotic in America. In 2021, private American investors rescued the facility because they recognized the national security imperative of domestic antibiotic production. Over the past 4 years, we have revived the plant, rehired and expanded our workforce, and restored America's ability to manufacture this life-saving medicine. Seniors account for a disproportionate share of antibiotic prescriptions. Adults over 65 receive antibiotics at rates 50% higher than younger Americans. Hip replacements, cardiac procedures, cancer surgeries, all life-extending interventions that depend on reliable antibiotic access. Pneumonia alone causes over 50,000 Americans annually, with seniors representing the overwhelming majority of deaths. Without antibiotics, routine surgeries become lethal gambles, and common infections become death sentences. Yet the U.S. remains dangerously exposed. China produces approximately 45% of the active pharmaceutical ingredients used in amoxicillin today, and supplies the majority of API used by Indian manufacturers. The result is most amoxicillin on pharmacy shelves represents Chinese chemistry with Indian finishing. We source exclusively from trade agreement compliant European partners, but we control only about 5% of the US market, despite having capacity to meet 100% of the national demand as we once did. If our facility were to close permanently, it would take at least 5 years and hundreds of millions of dollars to rebuild domestic capacity. That timeline assumes favorable regulatory and economic conditions that are far from guaranteed. More realistically, rebuilding could take a decade. Here is the paradox that brought me before you today. In 2021, our amoxicillin facility was rescued from bankruptcy by Jackson Healthcare, one of the largest healthcare staffing firms in the country. They've invested tens of millions in private capital to restore domestic manufacturing capacity. Because of that ownership structure, US Antibiotics is now excluded from competing as a prime contractor for federal amoxicillin contracts structured as small business set-asides. Since January 2023, we have sold roughly $1 million to the federal government through the federal supply schedule. During that same period, the Department of Health and Human Services spent approximately $40 million on foreign origin amoxicillin. That contract was structured as a small business set-aside, thereby excluding America's only domestic manufacturing manufacturer from competing. The irony is devastating. The company that saved domestic capacity cannot sell to the government that claims to prioritize supply chain security. Meanwhile, small business repackagers import Chinese and Indian drugs and slap American labels on the bottles. To revitalize domestic manufacturing of generic antibiotics and to protect our healthcare supply chain, I respectfully offer the following recommendations. First, create procurement pathways that allow domestic manufacturers of critical medicines to compete regardless of parent company size. Second, define domestic manufacturing to exclude simple repackaging of foreign products. Third, establish a strategic national stockpile procurement preferences for genuine domestic manufacturers. And fourth, provide long-term purchasing agreements that enable capital investment and workforce retention. We are not asking for subsidies or handouts. We are asking that when the government buys antibiotics, it prioritizes genuine American manufacturing. U.S. Antibiotics stands ready to secure America's antibiotic supply chain. We have the infrastructure, we have the expertise, and the commitment, but we need Congress to align procurement policy with national security reality. Thank you for your attention. I welcome your questions.
Thank you, Mr. Cashman. Next, we'd like to introduce our final witness, Dr. Eric Edwards. Dr. Edwards is the CEO of Flow, a domestic drug ingredient manufacturer working to secure the supply chain for medications. With extensive experience in the pharmaceutical industry, Dr. Edwards understands the nation's acute reliance on foreign generic medications. As CEO of Flow, Dr. Edwards has spearheaded Flow's partnerships with federal agencies like the Department of Health and Human Services and Department of War to shore up our supply chains and address the critical need for drug ingredient manufacturing in the United States. You may begin your testimony. Thanks for being here.
Thank you, Chairman Scott, ranking member.
Come on.
There we go. Chairman Scott, Ranking Member Gillibrand, and distinguished members of the committee, thank you for the opportunity to testify on a matter that directly impacts the health and well-being of millions of Americans, namely our nation's growing dependence on fragile foreign pharmaceutical supply chains and resulting drug shortages that continue to threaten patient safety, public health, and national security. My name's Eric Edwards. I'm a physician, scientist, and co-founder of Flow Corp, a leading American pharmaceutical company created to advance the domestic development and manufacturing of critical medicines and help reshore our medicine supply chain. I also continue to serve as a volunteer paramedic in Virginia, providing care in my local community where, during an emergency, the consequences of drug shortages are most acutely felt. In my own clinical experience, there have been moments when critical drugs, such as epinephrine for allergic emergencies, were simply unavailable. Substituting or improvising can mean the difference between life and death. Our pharmaceutical dependence is not just a public health concern, but rather a national security threat. If conflict disrupts Asian trade routes or trigger export bans, the U.S. could lose access to medicine ingredients needed for critical care, for oncology, for infectious disease treatments. Furthermore, military readiness could be severely compromised by disruptions in the supply chain as purposeful adulteration or export bans on key drug ingredients could also leave our warfighters without vital medicines. Over the past few years, Congress has taken significant steps to secure the rare earth mineral industrial base, including by expanding the national defense stockpile. That level of urgency is required for APIs. Just as rare earths underpin critical technologies, APIs underpin the entire pharma supply chain, and without them, we cannot make a single critical medicine. Flow was created to help solve this problem. In partnership with the United States government, we've built a state-of-the-art advanced manufacturing campus in Virginia, designed to domestically produce APIs at both small and large scale. Through our groundbreaking partnership with the Administration for Strategic Preparedness and Response, Flow is developing and supplying a broad catalog of essential APIs. For each program, Flow reconstructs the chemistry, sources starting materials domestically or from allied nations, and leverages state-of-the-art in development and manufacturing approaches, such as continuous manufacturing, to drive efficient, higher-yielding production, cost competitiveness, and a reduction of our environmental impact, all on U.S. soil. To date, we've completed 5 API development programs, filed 4 drug master files with the FDA, and have a dozen additional API programs in various stages of development. We're also proud to support the DoD-DOW in strengthening the warfighter supply chain. Importantly, we worked with the U.S. government to conceive of and build the nation's first Strategic Active Pharmaceutical Ingredient Reserve, or SAPR program, designed to function as a national security buffer for medicine supply chains. Through SAPR, we're working to maintain an inventory of ingredients for the most essential medicines and precursor chemicals identified by the federal government, helping to protect Americans during future public health emergencies until we can make these medicines on U.S. soil once again. Despite considerable progress, the onshoring movement remains fragile. For this transformation to succeed, certainty, focus, and sustainability are essential. No company, no matter how mission-driven, can sustain long-term domestic production without predictable demand and multi-year commitments. America must invest in additional advanced manufacturing capacity. Several key policy enablers are also required. First, to prevent future shortages and secure our supply chain, the government must create a comprehensive long-term plan as well as support a centralized authority to align policy and funding while bringing stability for patients and predictability for manufacturers. Second, the market will not shift back to the U.S. if buyers of essential medicines remain structurally rewarded for choosing the lowest immediate cost, even when those savings come at the expense of long-term security and patient safety. Third, to build enduring resilience, the administration and Congress must resource these programs with multi-year contracts, similar to how we support defense and energy infrastructure. This allows U.S. manufacturers to plan, to invest, and to scale with confidence. Fourth, we must level the playing field and ensure that domestic manufacturers can compete fairly against foreign producers who benefit from heavy tax subsidies, lax environmental and labor standards, and currency manipulation, advantages that artificially suppress prices and distort global markets. Finally, as previously recommended by this committee, it's critical that Congress prioritizes work to close the ACETRIS loophole. This loophole breaks the connection between Made in America and the actual location of pharmaceutical ingredient manufacturing, enabling continued dependence on foreign API supply chains, even in federal purchasing programs intended to prioritize domestic production. If we fail to act decisively, the next crisis will not be hypothetical. The shortages our great nation has been coping with have shown us the harm they can cause. However, if we succeed in creating a durable, competitive, and secure domestic pharmaceutical manufacturing industrial base, we will have restored one of the most critical pillars of national resilience. I thank this committee for your leadership in shining light on this issue. Pharmaceutical supply chain vulnerabilities are not inevitable. They are a product of choice. Together, we can choose to build a safer, more resilient, and more self-reliant future for all Americans. Thank you, and I welcome additional questions.
Thank you. I'm comfortable that we're going to see big change. I mean, we're going to see a plan, a supply chain plan, and we're also going to get legislation passed that's going to require country of origin for ingredients and for manufacturing. So let me turn it over to questions. We'll start with Senator Johnson.
Thank you, Mr. Chairman. Again, I just want to applaud you for holding these hearings. I think they're probably, if not the most important, some of the most important hearings we're holding in this Congress. I want to thank the witnesses for solid testimony and solid recommendations. It's interesting, I met with Dr. Patrick Soon-Shiung yesterday, a man of incredible accomplishment, but one of the things he did, he's the founder of American Pharmaceutical Partners. I mentioned this hearing. He said, well, that's similar to what happened in 2008 with heparin. This is not a new issue. We had contaminated heparin back in 2008 coming from China. It was on purpose. It was contaminated with a cheaper ingredient that could not be detected by normal measurements. And I see one of our witnesses shaking their head, but I'll ask you about it, but I'd like to enter into the record. I've got a white paper, I think, written by APP, one by the American Health and Drug Benefits, and then one from the Science Director, European Journal of Pharmaceutical Sciences, which which talk about this, but Mr. Kukla, you were shaking your head. Describe this. Again, this is nothing new. This happened in 2008, and here we are in 2025. We're describing the same problem which we have not addressed.
No, you're exactly correct, Senator. In 2007, 2008, somebody in China figured out how they could spoof the standard test for the active ingredient in heparin. They did so for economic reasons. We call it economically motivated adulteration. And they sold defective drug into the United States. That led to a kind of realization about how dependent we are on those foreign supply chains. FDA was given new authorities, the inspectional framework was rejiggered, but structurally—
We solved the problem, right? We fixed it.
Structurally, we are still headed in the wrong direction. We actually have heparin with U.S. API. Most of the heparin comes originally from the intestinal mucosa of pigs. China has a big pork herd, and most of the world's heparin comes from China. We have heparin API from the U.S., but it's more expensive than the Chinese heparin. So, if we're going to fix the problem, we have to sort of be willing to source from the U.S.
So let's talk, because I want to go back to the precursor chemicals, a new term I have, the key starting materials. Is that the same thing?
Yeah, so precursor chemicals, even going back all the way to petrochemicals, are the chemical starting materials that feed into the intermediates and ultimately the active pharmaceutical ingredients.
How many of those key starting materials, precursor chemicals, are there? Are we talking about hundreds, or are we talking about a few dozen?
No, thousands, and they are, the majority are made in China.
And that's a refining process.
Correct.
They're literally thousands. Are there a smaller batch of kind of general categories and then specific types within those categories?
I think it's important to note for this committee, and thank you, Senator, for raising this, that there are thousands of drugs in our supply chain themselves. And it is really critical for us as a nation to prioritize. We must focus. We cannot boil the ocean. We must secure our industrial base, focusing on those critical essential medicines that are prioritized by criticality, vulnerability, and reach. And so I would say there is a smaller subset that we can identify linked to a smaller group of active ingredients that are necessary to sustain the health of our population, because there are some medicines that have no therapeutic alternative and others where we're not as concerned about the supply chain failing because alternatives are readily available.
But, so one of the key precursor chemicals is oil itself, correct? But then we have plant-based. Would that be considered, things that are extracted from plants or from bacteria or from algae or from what? Can you just describe that chain starting from the most basic all the way up to API and then to the final drugs?
Sure. Certain key starting materials are derived from the petrochemical industry. Some, ironically, are derived from the rare earth mineral industry. There's a connection there. Some of these starting materials are synthesized to create solvents or reagents like toluene or benzene that we require in order to manufacture these active ingredients. Still others can be built leveraging synthetic biology, to your point, Senator. For example, one of our active pharmaceutical ingredients where we could not source the key starting material in any domestic location, we partnered with a company to leverage a synthetic biology approach or fermentation to help actually manufacture that starting material, which is one way to do it more cost competitively. So across the spectrum, there's a variety of chemical sources. Some are synthetically derived, some are biotechnologically derived. Regardless, it starts with mapping and knowing where they're coming from and focusing and prioritizing in order to ensure that we get a start somewhere.
So if I could just real quick, Mr. Chairman, I want to go to quick Tom Neely. What are your raw materials? Because you said you wanted to create the capability to produce API. So your raw materials are still API from where?
Well, the one I'm speaking of comes from China. Of the 13 product families that we produce, 2 come from China, and everyone else comes from outside the United States, but it's Europe mainly.
But again, because you're compounding these things or you're turning them into drugs, probably have a greater sense of quality control unless they're doing something like they did with the heparin, where they disguise the
That's right.
adulteration.
To me, it's all about vertical integration and the synergies you get from vertical integration. If you are able to build an API plant right next to a manufacturing plant, you're going to have some cost saves.
Okay.
And that's what it's going to take because China is so cheap.
Well, again, my guess, I know, Mr. Chairman, you're all over this, is we require labeling to know exactly where not just the API comes from, but the precursor chemicals. I think that will radically change because people will demand complete U.S. supply chain for their drugs. They'll demand it, and they'll pay a higher price. And by the way, drugs are not, particularly generic drugs, are not that high a spend in terms of our overall medical bill, price tag, so.
Senator Johnson, you're hitting the nail on the head because if I'm buying an API from Europe, for example, but they're getting their precursor from China, defeats the purpose.
Right. Well, thank you, witnesses. Thank you, Mr. Chairman.
Ranking Member Gillibrand.
Thank you, Mr. Chairman. In this series of hearings, we've heard about a variety of incentives to help support domestic manufacturing, such as targeted grants, low-interest loans, tax incentives. From your company's perspective, what is the most impactful economic incentive that would determine how you choose to invest and operate in the U.S.? What is the most significant factor currently limiting your ability to operate in the U.S.? And how do current procurement rules shape the market as a race to the bottom? How would purchasing and procurement signals from the federal government impact domestic manufacturing capability? You could start with Tom and go across.
Thank you, Ranking Member Gillibrand. For me, it's all about volume. Keep in mind that one dose at the factory that we work in costs $0.015. So we have to add volume, not price. Price is secondary, but it's really to maximize the capacity of our plant. So we have to operate 24/7. Today, we have the capability of producing 1.8 billion doses annually. And what right now we're doing is 1 billion. And because the distributors are focused just on price. So there needs to be a little bit of a break there. And in my mind, and I'm not an economist, but in my mind, if we had a system very similar to sugar, for example, because we cannot produce today all the domestic demand. But if we had a carve-out, a marketplace where you had priority, and if we are producing in the United States and we fulfill our total demand, that would help us tremendously.
Interesting. Alan?
Thank you, Senator. I mentioned that we have a couple of dozen generic drugs in development for our facility. Some of those are products that are selling right now at prices that, frankly, in the U.S., you couldn't buy an empty glass vial and fill it with sterile water for that price.
Got it.
So we're developing these products, but we don't expect to sell them unless and until there's a drug shortage. But as Mr. Neely says, if you have a pharmaceutical manufacturing facility, you'd like to run it full. That makes it efficient and amortizes the cost of all of your personnel and quality over more units. There are a lot of drugs that at today's prices we can make competitively in the U.S. But for those very low-cost drugs, which are also some of the most essential products, we've got to create a consistent demand for U.S. product.
Mr. Cashman?
Thank you, Senator Hildebrand. The federal government, in the case of amoxicillin, has structured all recent contracts as small business set-asides. And this policy exists for good reasons, helping small businesses compete against larger corporations. But when applied to critical medicines with severe supply chain vulnerabilities, it produces negative consequences
Got it.
for industry, taxpayers, and patients. U.S. Antibiotics would have closed permanently without Jackson Healthcare's rescue from bankruptcy in 2021. No one else stepped up. No private equity firm saw a profitable opportunity. No pharmaceutical company wanted to enter a low-margin generic antibiotics market. Jackson Healthcare viewed this acquisition as a national security imperative, not a money-making proposition. Because now with this patriotic investment, we're effectively barred from selling to the federal government as a prime contractor. The government's rules prevent only American manufacturers from competing while allowing foreign competitors, often subsidized by their own government, to dominate federal procurement.
Dr. Edwards.
Thank you, Ranking Member Gillibrand, for this question. First and foremost, you all may have seen today the U.S.-China and Economic Security Review Commission finally released their annual report calling for exactly what Senator Johnson spoke to, relating to urging the disclosure of country of origin for all APIs and key starting materials. And I think that is really, really important from a policy perspective. But the central obstacle in restoring the reliability of our pharmaceutical supply chain is not a lack of data here, it's actually a lack of aligned incentives. The market will not shift back to the United States if the buyers of essential medicines, including hospitals, clinics, wholesaler intermediates, GPOs, remain structurally rewarded for choosing the lowest immediate cost, even when those savings come at the expense of long-term security and patient safety. Candidly, information about quality sourcing and supply chain fragility is important. It's critical, but it's little more than a warning label if purchasers are neither financially supported nor contractually required to act on those labels. To change outcomes, federal entities should adopt procurement policies that value supply chain reliability, quality. Strategic investment in domestic sourcing helps save lives by strengthening national health security, reducing drug shortages, and mitigating the potential future for the wide disruptions they can cause.
Thank you. Thank you, Mr. Chairman.
Senator Tuberville.
Thank you, Mr. Chairman. Gentlemen, thanks for being here. Ms. Neely, you mentioned in your testimony the need for federal procurement reform. Do you currently sell the VA or the DOD?
We do, but it's a slow process right now. We need to see a lot of growth in that area. It's a very important channel for our products. It starts, I believe, with the 232, and then it migrates into changes in a few policies of the VA and DOD and Medicare, quite frankly, so that we can source the VA and the DOD effectively. At the same time, we maximize the capacity of our operation.
Is this a bid process?
There's two parts to it. There's FSS, which is the Federal Supply Schedule, and we've seen growth there. Now, we have bid unsuccessfully on several opportunities, and we have been shut out to date. The last bid, we got shut out by a firm that is Chinese American and that is partnered with India American. Now, they followed the policy, so I'm not saying that they didn't. There's gray area in the policy, but if it could be clearer and give us the opportunity and level the playing field, we will have won that bid.
So you said that in your open statement that you could quadruple your production. What would you need to do that?
So we have the facility set up so that all we would need is about $18 million of capital expenditure in equipment. The plant is available for additional packaging lines and granulation processing. So all we need is $18 million. Now, we have $130 million invested in the plant right now. But it comes down to a business decision and a return on investment. And so if we could get to that point, we would increase our capacity from 180 million doses a month to over 600 million doses a month. But right now, all we're doing is selling $100 million doses a month because the distributors all care about just is cost. That's it.
Thank you, Mr. Cookwell, is that how you pronounce that? Cockle?
Senator Cockle.
Cockle, okay. Your commitment to domestic manufacturing is a no China policy, is that correct?
Unless the product is not available anywhere else.
Yeah. What changes to the market price do you think are the most important to make U.S. generic drug production financially viable?
Thank you, Senator. As I mentioned, there are some injectable drugs that, with today's prices, are financially viable now. But there are drugs that are selling at 30 cents, 40 cents, and those aren't financially viable in the U.S. And so we need some system where purchasers select for quality, select for domestic manufacturers, and if that costs a little bit more, we probably need to make them whole for that cost.
Yeah. Thank you, Mr. Chairman.
Thank you, Senator Tuberville. Mr. Neely, let's talk about inspections. So does the FDA tell you when they're going to inspect you?
No.
Okay. So what if they walked in and found a violation, what would happen?
Depending on the severity of that violation, if we received a 483, we would be closed. And a 483 is against the law. So John Schultz, our president, and I would probably be indicted.
All right. The FDA often announces foreign inspection weeks in advance. It gives manufacturers plenty of time to prepare. Just recently, the FDA found an Indian facility in violation citing flying birds, skittering lizards, and roaming cats in the right of the manufacturing plant. If that happened to you, what would happen?
We would be closed. But the difference is right now in India, since we receive so much generic product from India, that all they do is either they move their operation to another plant and swap the different medications produced, or they threaten the United States by saying, if you close this plant, you're going to incur a shortage of product. That's the national security issue that we face today.
Have you ever heard of the FDA waiving a violation? Would they waive a violation for you if it was going to cause a shortage?
No, sir.
Have you heard them ever waive a violation for a foreign manufacturer?
Anecdotally, I've heard it in the press.
Okay. Mr. Cockle, how does Civica's motto serve to limit shortages?
Thank you, Senator. We do a number of things that are different from the traditional generic supply chain. It starts with long-term commitments. So the hospitals that partner with Civica commit to multi-year fixed volume contracts. We, in turn, provide that commitment to our suppliers. So that creates a level of stability that doesn't usually exist in the generic drug business.
You have to commit to price too then.
We commit to price as well.
Price and, yeah. Okay.
That's right. And so that lets companies know that they're going to have market share, lets them invest in quality, gives them a commitment to that product. Another thing that we do that is unique is we target a 6-month buffer inventory of every drug. And the reason we do that is if somebody drops out of the market, then we can draw down on that inventory while somebody's making new batches, because it takes a while for companies to ramp up production, even if they have FDA approval to make that drug. We also do a really rigorous quality oversight process of our suppliers. So we're going out actually visiting their facilities, walking the floors, doing an audit, looking at their records, and then we do that on an ongoing basis to ensure that we're choosing suppliers that are less likely to have a failure to supply in the future.
Thank you. Mr. Cashman, what would happen to our nation's supply of antibiotics if your plant were closed?
Chairman Scott, we would be completely dependent on India and China. All of the API comes from either China or India, with the exception of one producer several producers in Europe. With our plant closing, there would be no finished dosage forms whatsoever produced in the United States.
And how many months or years of supply of amoxicillin do we have in the country? Do you have any idea?
No, sir, I don't know that. What I can comment on is we keep a year's worth of API supply at our facility, and we have about a year's worth of finished goods products in our facility as well.
Okay. So does the FDA inspect your facility?
Yes, it does.
Okay. And if you had flying birds and lizards, what would happen?
We would be shut down. That
Would they
be the
care if
end.
there was a shortage?
Excuse me?
Do you think they would care if there was a shortage of amoxicillin?
Chairman Scott, no, I don't think they would care.
Dr. Edwards, why is it so important that we make active drug ingredients or APIs right here in the United States?
The active pharmaceutical ingredients are the components of the drug that give that medicine the therapeutic effect. Some might say it's the most critical component, given that definition. For us, we've lost this industrial base over 4 to 5 decades now. And it's gotten to the point where, in many cases abroad, we rely on a single source outside the United States to produce the medicines that our seniors and Americans rely on every single day to treat a variety of acute and chronic issues. For us, this truly is a matter of national public health security, but it's also a matter of national security as our warfighters on the battlefield have to deal with the fact that they may be having to utilize a drug that is made with ingredients coming from a potential foreign adversary. It's simply unacceptable.
Mr. Neely, is it too much to ask that plants don't have flying birds and skittering lizards?
No, sir, it's not. And I think it's important to state that quality is not cheap. For every dollar of expense that we spend, 38 cents is spent on quality. What I'm seeing
Say that
is
again.
every dollar of expense that's spent in our plant, 38 cents is based on quality, is spent on quality. So what I'm seeing is our foreign competition is cutting their cost so that they can come up with the lowest price possible to sell to the distributors to get the contracts or get the formulary.
Sure.
Related, drug manufacturers around the globe are frequently the target of cyber attacks. These attacks are perpetrated for a wide range of reasons by competitors, adversarial nations, even non-state actors, and can cause disruptions in the supply chain that impact the availability of key drugs and their components. Which link of the supply chain is most vulnerable to cyber attacks, and in what ways does cyber resilience protect domestic drug production? What types of measures does your company take to promote cybersecurity? Approximately how much does this cost out of your operating budget? And for Mr. Cockle directly, how can new and existing domestic drug manufacturers engage with CISA, the FBI, DHS, and other federal authorities for robust cybersecurity protections? You can start, Mr. Cockle.
Thank you, Senator. I think it's an important risk to flag. We often think about what if a country were to cut off our supply, but you can shut down a pharmaceutical plant the way you can shut down any business with a cyber attack or a cyber ransom attack. And if you Google India cyber ransom attack pharma, you'll find a long list of companies there that have been targeted, which is not to say that we're not also at risk in the U.S. Of course, those sorts of attacks know no borders, but it's reasonable to think that a company that's cutting corners on its manufacturing quality is probably not also investing in cybersecurity the way it should. So there are a number of federal programs to support U.S. manufacturers, but there's no doubt to ensure our supply, we need to be ensuring that our domestic manufacturers and our manufacturing partners have top-notch cybersecurity.
Yes, thank you. Ranking Member Gillibrand, this is a critical aspect of the pharmaceutical supply chain and resiliency across them, and I think every single node of the supply chain is at risk, not one more than another. In combination and in partnership with the Administration for Strategic Preparedness and Response, FLO's government program incorporated cybersecurity into the infrastructure build from day one. We have partnered with the FBI, Homeland Security, and CISA in order to test our systems and to come on top of this infrastructure build because we know that fragility and that vulnerability is real. In 2017, for example, Merck experienced a ransomware attack that ended up having an impact of over $1 billion in potential damages. So this is not something that's theoretical. It's happened in the past. And in the age of where we are today and the vulnerabilities that we are experiencing from a geopolitical conflict potential, this is only going to become even more of a threat. So for us, it's about not building an infrastructure and then trying to decide on, let's layer cybersecurity on top of it. It's about integrating that cybersecurity posture from day one and ensuring that anyone who works alongside the government supply chain to secure our critical industrial base is making sure that we're prepared for the future as a matter of national public health security.
I do think that the new regulation around DSCSA and serialization has improved so that we track every batch, every case, every bottle, down to the consumer level. So if there is ever a recall, we can identify where it is.
Helpful. Also related, Mr. Neely, you talked about that there needed to be some support. You weren't specific about what the support was, but I want to challenge some of the witnesses about what supports would actually matter. Dr. Edwards, you mentioned your groundbreaking partnership with the Administration for Strategic Preparedness and Response, known as ASPR. In your testimony, Dr. Cockle, Mr. Cockle, you mentioned in your testimony that your facility in Petersburg, Virginia is funded with U.S. government support with ASPR through the Center of Biomedical Advanced Research and Development Authority, known as BARDA. So can you both, Dr. Edwards and Mr. Cockle, speak about your experiences, what's working, what's not working, and Mr. Neely and Mr. Cashman, if you want to add what types of support you'd want, because it's relevant for us, because we are definitely going to do the transparency stuff. That's like very much common ground, something the chairman and I want to work on immediately. But more is needed, and we need more color on the more. Go ahead, Dr. Edwards.
Thank you for that question, Ranking Member Gillibrand. You know, ASPR has undertaken a critical mission since we first got started with them over 5 years ago, through now multiple administrations and a pandemic, and on the other side of that pandemic, to try to address pharmaceutical supply chain sovereignty. However, they need help. The GAO has repeatedly recommended that HHS implements a formal department-wide mechanism to coordinate drug shortage activities. This would ensure that FDA, CMS, DoD, DOW, and ASPR, and other agencies work together rather than in silos, which is really what is happening today. There need to be clearly defined roles, goals, and outcomes among the agencies. And finally, ASPR and any other agency that is tasked with this extremely important mission should ensure that they receive long-term sustainable funding as well to support companies like ourselves, but also others who are working to bring back this industrial base, as this is not something that Flow can do alone. You need multiple flows. You need multiple companies working together and really helping them raise up their posture and have the support they need. Going back to that centralized authority would be a critical step in the right direction, specifically.
Thank you, Senator. The funding that we received from ASPR to invest in our plant was very important, taking into account the capital costs and the startup costs. Nearly a third of that funding came from ASPR. That was during the pandemic when there were resources to make those kinds of investments. In recent years, the Office of Industrial Base Management and Supply Chain within ASPR, which is the office that has the expertise and the mandate to make these sort of targeted investments, has had very low, very flat budget and hasn't had the ability to make additional investments. So they can do more, but we have to support them to do more.
And Ranking Member, mine's pretty simple. I would think that this committee would want a plant that's just fairly new to be at full capacity. To be at full capacity, an $18 million grant to build out 3 packaging lines and another granulating piece of equipment could quadruple the throughput through our operation.
Yeah, I would second that, ranking member. I would also add that we need a very comprehensive approach. Strategic antibiotic manufacturing fund with targeted grants and low-interest loans would be very, very helpful, similar to the CHIPS Act. Second, tax incentives for domestic API production, including immediate expensing of new equipment and enhanced R&D deductions. Third, supply chain visibility, which you mentioned, which I think is so important for patients and doctors and hospitals to know where their medications come from. Fourth, recognition that essential medicines are national security assets, making manufacturers eligible for industrial-based support available to other critical sectors. You know, there's a lot of different tools we could employ here, but we need a sustained commitment. I think that's a message we hear from every one of us up here. And it has to be a long-term sustained commitment. Thank you.
So I think, Mr. Call, didn't you say about, you were talking about the hospitals ought to be compensated for quality? Didn't you say that in your testimony? So right now, I think under Medicare Advantage, they are. And I think, but it has nothing to do with medicines, right?
Yeah, thank you, Senator. Let me clarify. What I really meant is right now the thing that drives generic drug purchasing is price.
Yeah, only price.
To the exclusion of everything else. Yeah. And what we need, I think, is a system, as we have at Civica, where when we're looking at a supplier, we're looking at what supplier is less likely to fail us in the future. What are their quality systems? What's their quality maturity? And we need to drive purchasing to factor that in, which is not to say we become indifferent to price, but we ought to weigh some other things that are pretty important along with price when we choose what drug suppliers we're going to use.
You know, we have to look at this, but I bet CMS already ranks people enough on quality that they have the ability to put information out whether hospitals and probably Medicare Advantage for sure, or all the health plans are doing this. They probably, and I bet they already have that ability without even any new legislation, if it was important to them. So I'll find out. So what would happen? What would happen for each of you if you got 100% of the volume from the Department of War and the VA of the things you do today? What would happen to your business?
Quite frankly, Chairman, I would make money for the first time in 10 years.
I think every company would welcome that, and for the company that got that business, it would be tremendously significant. But I do want to make the point that DoD and VA are both 1 or 2% of the total market. And so changing how they procure drugs, very meaningful to whatever company gets that business, but it's not enough to shift the whole market and bring back. For that, we're going to have to get into Medicare and the commercial market.
Right. Okay.
In our case at US Antibiotics, it'd be transformational. It would be so important for us to have that volume. It would give us a solid base of manufacturing volume to grow our commercial business on as well.
And in our case, it would help us baseload our facilities, support the 1.5 million active duty soldiers, secure a supply chain of 25 to 50 drugs that these soldiers depend on a daily basis, and enable us to send a market signal that's real. That will help spur additional private investment and help us grow and sustain our business when that type of demand signal starts to reveal itself. Because where do we start? We start on the federal supply schedule and what the government actually has authority to do. Ultimately, it can then move into CMS and some of the other challenging environments, but starting somewhere is better than nowhere, and we need to get started.
So what would happen to, let's take it from the patient standpoint. If that happened, what would be the benefit to a soldier or sailor or to somebody in a VA facility? What would happen to their quality of care?
Chairman Scott, we know that not only patients but also physicians, they don't have a clue where their medicines are made or what they're using. So the first thing that we would emphasize in this is that we would restore trust. We would begin making sure that we are able to restore trust in the quality of these medicines. We would know where they are coming from. And it's really important that we not only emphasize location, but we also emphasize quality manufacturing as well. They both go hand in hand. So I think what would happen is we would experience the health and well-being, and more important, the national resiliency. We would experience a change in that is significant. It's significant for the well-being and the quality of care that's being provided, but based off of some of the testing and the reports coming out of the Pentagon and Kaiser and others, we would hopefully experience less adverse events or subpotent medications that have entered our supply chain when we know where they're coming from.
And if I could just expand on that, I did an informal poll of my family. We take 23 generic drugs. Now, they're all Medicare, okay? Of the 23, 20 are produced in India, 2 are in China, 1 in Canada. Not one is made in the United States.
And you probably, and you don't even know where the ingredients are from.
The only way I was able to find out is because I'm in the industry. So I researched the NDCs.
Yeah.
But for example, I take a cholesterol medication. It's a repackaged. It's owned by a distributor. So you would think, okay, it's a United States product. You do the NDC, it comes from a plant in India. It's labeled in India. India ships it to the United States. They send the bill to Ireland. But the owner of that business is here in the United States. But they never touched that medicine.
Right. So, did you want to add something?
Well, I'll just make one additional point, Senator, which is I think there's an important difference between a product defect on a given day, which is important, and that's a risk to a patient, but it's different from a company that has inadequate quality systems, and at some point in the future, FDA is going to come along and find they're pouring acid on their records or cutting corners in some other way, and they'll have a failure to supply. And so part of what we want to do is shift the market to companies that are less likely to cause a drug shortage and have a failure to supply, which doesn't necessarily mean that on a given day, their product is defective.
We had testimony from Dr. Ball from the University of Indiana that you have over a 50% increased chance of hospitalization and death if you take a generic drug from India or China. So would any of you like to talk about how the Department of Commerce should use their Section 232 investigations to support domestic manufacturers? Anybody want to comment on that?
Well, I will, because I think it jumpstarts the whole reformation of what we need to do. It provides some ability to go in and fix the procurement problem, number one. And so, you know, we have a long time, it seems to me, to reform the entire industry. But we've got to get started, and we've got to get started as fast as possible. That 232 is the first part of making sure that we can respond to other problems that we have in this industry faster.
Right. Mr. Cashman, why don't you have contracts with the Department of War? Or you don't have contracts with the Department of War or VA, right?
No, Chairman Scott, we do not. The reason for that is we're not considered a small business. Many of the amoxicillin contracts, or all of the amoxicillin contracts in recent years, have been small business set-asides. Because Jackson Healthcare, a fine Georgia corporation, made an investment in our facility and they spent millions of dollars saving our facility is not considered a small business, and therefore we can't compete for those small business set-asides.
Are any of you familiar with any independent quality testing for imported medicines from China or India? Is that happening?
Senator, I'm not aware of any.
Anybody else?
The Department of Defense has a quality investigation or testing program which is something we think all imported medications should have tested before they're sold in the United States.
Okay.
I'm familiar with a couple of pilot programs that are looking to
It
test.
doesn't surprise you that every drug that comes in is not tested?
Yes, I
I mean,
think,
think about it. The USDA, you can't buy meat unless you have an USDA inspector at that plant, right?
we operate off of an honor system, Chairman Scott.
For something you put in your body.
Correct.
But we don't do it for cattle.
Or groceries, or clothing, or anything else.
I mean, that is,
And yet at our plant, excuse me, but at our plant, we have an end-to-end testing process and program. So we test every raw material that comes into our plant. We do efficacy testing, we do dissolvency testing, we do breakage testing throughout the entire process, from the beginning of the raw material to when it's packaged.
all right. All right, do you have any other questions? All right, does anybody else want to add anything?